Good morning. I think people are still logging on, so we're going to give people a couple of minutes to get logged on to this webinar, but we would very much like to welcome you to the launch of the Influenza Vaccines Research and Development Roadmap Initiative, and we'll be getting started in about a minute. Thank you. Okay, I think I'm going to go ahead and get started. I know some people are still logging on, but I think in the interest of time, we'll go ahead and begin this event. And I, again, very much appreciate you all listening in and being here this morning. So what I'd like to do first is just welcome you and again, thank you for joining this virtual press briefing informational webinar today. My name is Chris Moore, and I am the Medical Director at the Center for Infectious Disease Research and Policy, known as CIDRAP, at the University of Minnesota in the US. I'll be the moderator for this morning's event, or afternoon's event for some of you. Please note that media are welcome to quote directly from comments made by our presenters. Also, we have invited members of the influenza research community to this webinar to promote awareness of the launch of this Influenza Vaccines Roadmap initiative. Next, I'd like to briefly introduce the speakers in the order that they will be presenting. First, we have Dr. Michael Osterholm, who is the director at CIDRAP, which is located in Minneapolis, Minnesota in the USA. And then we have Dr. Charlie Weller, who is head of vaccines at the Wellcome Trust, located in London, the UK. And then Dr. Martin Friede, who is the coordinator for the Initiative for Vaccine Research at the World Health Organization in Geneva, Switzerland. And then our final presenter will be Dr. Kang, who is a professor of microbiology at Christian Medical College in Vellore, India, and she's also an expert in vaccine research. We'll have some time for questions following the brief speaker remarks. And first, we'll take questions that have been submitted in advance for the briefing, and then we'll take questions from the Q&A list. If you have a question during this briefing, you can enter it into the Q&A. We would prefer you use the Q&A function rather than the chat function. Also, please give your name and affiliation along with your question, just so we can record that information. And I just want to let you know, we may run out of time, so we may not be able to take all of your questions, but we'll do our best to get through as many as we can. So before we begin, I'd also like to just take a moment to thank other members of the steering group for this project. These include Joe Breezy from the Task Force for Global Health and formerly with the CDC, Bruce Gellin from the Rockefeller Foundation, who was with the Sabin Vaccine Institute during most of the development phase of this roadmap, Josie Golding and Peter Hart from the Wellcome Trust, Stacy Nobler, also from the Sabin Vaccine Institute, Ann Moen from WHO, and Ross Hollingsworth from the Bill and Melinda Gates Foundation. I would also like to thank members of our expert task force. They provided a great deal of input into the development of this roadmap, and we will share a full list of those partners in the fact sheet after this briefing. We will also have a recording of this event, and we will make that recording available after the call. With that, I'll hand it over to Dr. Osterholm for our first presentation. Mike, please go ahead.
Good morning, good afternoon, good evening, and thank you, Chris, and thank you to all of you who have participated in this amazing effort over the course of the past 3 years. Let me just start out by saying the obvious. Given our current experience with COVID-19, we now all know how devastating a global pandemic that involves an easily transmissible respiratory virus can be. But influenza could cause one just as bad, if even worse, than COVID-19, with estimates showing that more than 30 million people could die within 6 months after the onset of a severe influenza pandemic. In addition, seasonal influenza causes annual epidemics in countries around the world, leading to hundreds of thousands of deaths each year and about 5 million serious illnesses. That is, illness severe enough to require hospitalization. Further, we should not be lulled into a sense of complacency about influenza, since we have not had very much influenza activity since the beginning of the pandemic. Eventually, and even possibly this year, we will see a resurgence of seasonal influenza as pandemic mitigation measures ease around the globe. During the 100 years between 1918 and 2018, we had 4 influenza pandemics. This clearly illustrates the risk of pandemic influenza, and it is a real and serious threat. The question is not if we will have another influenza pandemic, but when. It's against this backdrop of annual seasonal influenza and the threat of pandemic influenza that the concept of the Influenza Vaccines Research and Development Roadmap, was referred to as IVR, was conceived. Work on this effort began even before COVID-19 first raised its head worldwide. It took 2 years to generate the roadmap through a series of stakeholder engagement activities. In addition to our steering group, we worked extensively with a task force of 16 members, all of whom are experts in one or more areas of influenza research or prevention and control. We have recently expanded our task force to include roughly 20 additional members as we move into the implementation phase of this roadmap. We've also held a series of online webinars with invited experts from around the world. These discussions involved 147 select subject matter experts from nearly 100 organizations. Finally, we posted the roadmap online for a period of public comment, which elicited additional input from 109 distinct contributors. Ultimately, shareholders from 29 countries participated in this global and multi-staged engagement process. I want to thank all of those who shared their time and expertise with us to get us where we are today. The IVR has a 10-year timeline that identifies high-level strategic goals and accompanying milestones to track progress towards improving the effectiveness of seasonal influenza vaccines and accelerating the development of broadly protective or universal influenza vaccines that would cover all influenza risk, seasonal or pandemic. The IVR is aimed at the global ecosystem of influenza vaccine stakeholders. This includes scientific and clinical researchers, funders, public health policymakers, industry scientists, vaccine manufacturers, regulators, and advocacy specialists. Today, as the world continues to absorb lessons from COVID-19, we have, as a global consortium, produced this comprehensive influenza vaccines R&D roadmap. It shows us how we can usher in a new era of influenza vaccines to better protect all of us against influenza. If we embrace it, we could potentially tame seasonal epidemics and prevent or rapidly mitigate a potentially devastating influenza pandemic. Again, thank you for being with us today, and I'll turn it back over to you, Chris.
Thank you, Mike. Thank you very much for those remarks. And now our next speaker is Dr. Charlie Weller from Wellcome Trust. Charlie, please go ahead.
Chris, and thanks, Mike. So the roadmap development process was supported with funding from Wellcome. And one of our goals here at Wellcome is to enable the development of improved vaccines for a range of conditions, not just influenza, as well as making sure that they reach those who are most in need. When we decided to move forward with this project, we were really interested to understand why we didn't have better influenza vaccines, especially when flu research ranks number 4 in terms of global research investment. We also recognized that influenza was and still is the greatest pandemic threat, and this remains true even as we start to emerge from the COVID-19 pandemic. There are many outstanding research gaps to developing improved influenza vaccines, and there are many actors spanning research and industry engaged in the space, which is really good to see. But until the roadmap was developed, there was little clarity on what research gaps remained and which of these research gaps were most important to fill. We believe that this lack of coordination and prioritization has been one of the barriers to moving the field of influenza vaccines forward. And one of the main goals of the roadmap, therefore, is to really provide this framework of priorities and a mechanism to improve internal coordination over time. Our hope is that this roadmap will promote coordination of research funding and bring together the key actors so that we have the best chance to develop new and improved vaccines to tackle influenza. Now, we do recognize that there are 2 different approaches to improving influenza vaccines. On the one hand, there is a more stepwise, incremental approach to gradually improving seasonal influenza vaccines. And on the other hand, there's a more aspirational approach of creating broadly protective and universal vaccines. And we wanted to see a way forward which enabled both of these approaches to progress, neither at the expense of the other. We believe the roadmap achieves this and thereby aligns with our goal at Wellcome of catalysing developments of new and improved vaccines. We also recognise that there are a number of forces that influence vaccine development, and funding alone is often not sufficient. Political will and coordination of partnerships are also key to enable successful vaccine development. At Wellcome, we've got an interest in improving equitable access to vaccines around the world, and we believe that improving influenza vaccines now can help with that effort. During the 2009-2010 H1N1 pandemic, for example, vaccines arrived after the pandemic peaked in many areas. During that pandemic, there was also a lack of equity in access to vaccines, with high-income countries getting more vaccine earlier than low-income countries. And we've now seen a similar state of inequity in access to vaccines in COVID-19. If we can improve influenza vaccines in a way that more countries can have routine influenza programs in place, this can go some way to helping with vaccine distribution more broadly. In addition, we can also improve global manufacturing capacity to extend it to more areas of the world. And these are additional important considerations that we need to consider as we tackle these issues. I'd like to close by on just one thought, which is, while an important measure of the roadmap success is to track how many milestones are achieved over time, for me, one of the more important key measures is whether the roadmap receives significant acceptance and engagement by the target audiences, such as researchers, industry partners, and decision makers, many of the people who are listening today. And we really don't want the roadmap to be a document that sits on a virtual shelf. We want it to be used, we want it to be useful to those influenza R&D communities and to guide and focus research in this area. So on that note, I'm going to pass back to Chris again. Thank you.
Excellent, Charlie. Thank you. Thank you very much for those remarks. Next, I'd like to go to Dr. Martin Friede. Dr. Friede, go ahead.
Okay, thank you very much. So let's look at this roadmap really from the perspective of the low and middle income countries, because this roadmap was intended not only to help us prepare for a pandemic, but improve the response to the seasonal vaccines, especially in low and middle income countries, where the current suboptimal efficacy of these vaccines, where we have to give the vaccines every single year, they've got a suboptimal efficacy. It's not very good. Means that the cost of doing influenza vaccination is very high. And for many countries with low resource settings, they look at this and say, well, that's too much for us to invest in. However, in these countries, there is a significant burden of influenza causing hospitalization and causing deaths. So we definitely need, for these populations, we need better vaccines. We need vaccines that protect for a longer period of time, that we don't have to vaccinate every single year. And to achieve this, this means the vaccines must also protect against a broader range of strains, that we don't have to be adapting every single year to the strains. But also in these countries, we need to be recognizing that it is protection against severe disease that is the most important. It is not the protection against the sniffles that is really of great concern. Now, in 2019, WHO released the Global Influenza Strategy. This was a document that called on all member states to implement an influenza program, influenza research program, influenza control program. And a major objective of this strategy document was research and development. Now, the research and development in this document, it covers the development of diagnostics, because we need to be able to diagnose the influenza that's taking place. The therapeutics, that we're able to treat people coming into hospitals with influenza. But very importantly, vaccines. And it is the vaccine research and development agenda which has really become the focus of the roadmap that we're launching today, which has got into detail of what is the R&D that is required to get us to better influenza vaccines. So we have to recognize the current vaccines that we've got are all based on a technology that was originally developed in the 1940s. This was growing the virus in eggs. and isolating from that either a fragment or the whole virus, which is then used as the vaccine. Now, this is an incredibly inappropriate technology for us to be using in the 21st century. First of all, the eggs mean that you can't get access to in the event of an emergency. You don't suddenly snap your fingers and you have 10 billion eggs. The process is slow. It takes months and months to produce vaccines in eggs. And the process is unreliable. Because it's slow, we have to make predictions, and sometimes we're wrong. And even when we're right, the efficacy of these vaccines is suboptimal, to be best, around about 50%. And sometimes it's low, very low, 10%, sometimes even less. So although there's been incremental development over the last several years, tissue culture vaccines, we've got high-dose vaccines, we've got adjuvanted vaccines, we still do not have vaccines that really meet our need of a vaccine that protects against a broader strain of viruses for a longer duration of time. But we've also learned, unfortunately, through this COVID pandemic, what can be achieved. We've seen how research and development can be accelerated. We've seen how novel technologies such as mRNA can be applied to solve problems that previously appeared intractable. And so this is one of the key focuses, one of the most important focuses of this roadmap, of how we build on these emerging technologies, how we build on the lessons that we've learned from influenza in the past, from COVID now, and how we make better vaccines so that in the future, it is not only pandemics that we prepare back for, but also throughout the world that we've got access to control of seasonal vaccines. I'll pass back to you, Chris.
Great. Thank you very much, Dr. Friede. That was great. And our last speaker is Dr. Kang. Jerry, please go ahead.
Thank you very much, Chris. So after 2 years and hours and days of discussions across hundreds of people, what have we come up with in the roadmap? The 10-year strategy is organized around 6 key areas of research, each of which identifies barriers, knowledge gaps, and specific technical milestones for measuring progress. The first key area is looking at vaccinology for universal vaccines. And if we could do this, we would end the need for seasonal vaccination and also dramatically strengthen pandemic preparedness. There are many promising universal influenza vaccine candidates that are under study, but their clinical development requires overcoming a lot of significant technical and logistic challenges, such as conducting clinical trials over multiple seasons with different circulating viruses in people who have different infection histories. The second key area is looking at vaccinology for seasonal influenza vaccines. One strategy for improving efficacy of seasonal vaccines is to be able to make them faster so that we can make them closer to the influenza season, and that makes forecasting of which strains are going to be dominating more accurate. Faster production could be achieved by one of the vaccine approaches or platforms that we've used for COVID-19. We could also look at other approaches for improving the effectiveness of seasonal vaccine formulations for preventing infection and severe disease. The third area is virology. Despite all the work that we've done on influenza viruses, there is a lot that we don't understand. We need more insights into the changes that occur in influenza viruses as they circulate in humans and animals around the world. And the IVR focuses on research that is aimed at improving our understanding of virus evolution and our ability to identify novel viruses that may have pandemic potential. Another key issue is the need for improved global surveillance to better monitor and track influenza viruses. If there's one thing we've learned in the past year, it's that it can be done. Immunology is a fourth key area of the roadmap. You know, it's incredible that we know a lot about mice and we don't know a lot about humans. So that's been a major barrier. We don't know how to make a durable immune response to influenza vaccines. So really protection that lasts for several years. So these, and there are other important areas in immunology that are described in the roadmap. A fifth focus area is the need to improve animal models, both in, humans are animals too, so we need human infection models as well. And we need to look at how we can do this safely and ethically so that we learn as much as possible from human studies where volunteers are vaccinated with new vaccine candidates and then challenged with an influenza virus. These studies are ongoing in some parts of the world, and they really do need to be expanded. Then we have policy, financing, and regulation as the last area of the IVR. This calls for new communication and advocacy efforts, really targeting all stakeholders, policymakers, funders, researchers, and the public health community to highlight the benefits of developing improved vaccines for seasonal and pandemic influenza, including for use in low and middle income countries. The IVR also calls for efforts to explore the feasibility of creating new public-private partnerships with sustainable funding aimed at mission-driven R&D for universal influenza vaccines. We also advocate for a global strategy to support the growing focus on establishing and expanding sustainable vaccine R&D and manufacturing in low and middle income countries, which is a key need for equity in access to vaccines. Based in India, where we don't have an influenza vaccination program, I think the roadmap offers a lot of value, a lot of potential to combat influenza in our country and globally. If we had improved flu vaccines that could avoid the need for annual reformulation, that would be a huge breakthrough. We have 1.3 billion people. We cannot vaccinate them every year. This roadmap is an important opportunity. It's an opportunity to step up our global engagement, step up our science, our collaborations, and to build new research networks, particularly those that include and are in low and middle income countries. We need to make a concerted effort to find the right partners for this project from around the globe to make sure that the roadmap is a success and that we wind up with more equitable manufacturing and distribution of influenza vaccines. Thank you so much for listening, and back to you, Chris.
Great. Thank you very much, Dr. Kang. I really appreciate all of the remarks that have been made so far, and I want to thank each of you. And I'd also like to turn it back to Dr. Osterholm to just give some kind of wrap-up concluding remarks to this part of our event.
Well, thank you, Chris, and thank you to all the speakers this morning and all of you who have invested so much time in this. I hope that the comments each of us have provided give you a sense of why this project is important, how the roadmap was developed, what we hope to achieve with it, and how it aligns with the WHO Global Influenza Strategy for 2019 to 2030. I also want to note that we have worked closely with our influenza partners at the U.S. Centers for Disease Control and Prevention on this project. Although they were unable to join today's discussion, Dr. Sam Poisner, who is the acting director of CDC's National Center for Immunization and Respiratory Diseases, shared some thoughts on the importance of the IVR in shaping the future of influenza vaccine development. He highlighted this in a letter to us, and I quote, "The CDC enthusiastically supports the IVR, and we are confident it will provide an effective framework to focus the activities and investments of global stakeholders and encourage others to join the fight against flu. We are hopeful that it will be a catalyst for change and look forward to our continued partnership to support improving influenza vaccines." End of quote. In closing, I also want to stress a key point. Success of the roadmap depends on all of those who are part of the influenza R&D community and who are currently working to build new partnerships. We need community involvement to track progress, to coordinate funding and research, to identify R&D gaps, and to determine ways to address those gaps. To do this, we need researchers, funders, regulators, and industry to work together as we go forward. Thank you.
Great. Thank you, Mike. And thanks again to all of our presenters. And that's the end of our prepared remarks for this particular webinar or press briefing. What we'd like to do now is move into the Q&A part of our time together. And we're going to take some questions that we received ahead of time first. And then again, if you have questions, please enter them into the Q&A function on your Zoom screen. And then also please put your affiliation in addition to that. So I'd like to go ahead with the first question. And I think we'll start with Dr. Friede. Martin, how long do you think it's going to actually take for there to be a universal flu vaccine? Do you think 2030 is realistic, or can you make some comments about that issue?
Making predictions is very difficult, especially predictions about the future. So what is certain is that by 2030, we will have better vaccines than we currently have. Vaccines that maybe protect against a broader spread of viruses, maybe vaccines that can provide longer lasting protection, certainly vaccines that can be manufactured quicker and therefore closer to the season. But will we have vaccines that protect against all viruses for long, very long periods of time? That remains unknown. So I think as we go forwards, we'll see.
Great. Anybody else want to make a comment on that? Mike, do you want to add anything?
No, I think Martin has it. I think one of the things we have to do is not be basically hampered by what has happened in the past. We've seen what COVID has done to the vaccine world and how it has changed the speed, the dimensions of what we dream about can happen. And I think that now we have to take that energy, we have to take that example and say that the past does not at all have to be indicative of what we can have in the future. And now is the time to take that energy and that concern that we now so well appreciate with what a pandemic can do, and to highlight that in the kind of work that I think can fit exactly into the model that Martin just shared.
Great, terrific. Okay, the next question, and I think we'll have Dr. Weller answer this question. And kind of, you touched on it just briefly there, Mike. How promising is the new mRNA technology looking in terms of being applicable and applied to influenza?
It's a great question. And I think it's extremely exciting, the progress that we've seen over the last 18 months throughout COVID, that we've seen with the mRNA vaccines from a scientific and innovation perspective. But we need to remember that having a vaccine isn't the same as having vaccination. And there are many different characteristics of different vaccines that are maybe more or less suitable to different places in the world, different people in the world with different underlying health conditions. So having a portfolio of different vaccines with different characteristics is still something we need to maintain for flu, for many different diseases. And we also need to remember that one platform like mRNA or protein platforms may not be suitable for every disease. So we do need that diversity of portfolio when we're thinking about different diseases as well.
Yep, that sounds great. Okay, the next question is, what are some of the key improvements in vaccines currently under development to ensure longer or permanent immunity? Terry, can you take that question?
Sure. So in thinking about how long we can make vaccines provide protection, I think we need a deeper understanding of the immune response. We know that there is a way to design vaccines to elicit stronger and more durable immune response. It's also possible to add things into vaccines that help you have a longer response. So looking at adjuvants, looking at designing antigens is critical. But in order to do that, we really need to evaluate those vaccines in clinical trials that measure the duration of protection. And unfortunately, we have not been doing the kind of long-lasting studies that are really required. So bringing together people who do vaccination and people who do immunology, virology, and now the microbiome as well is absolutely essential so that we really understand what gives us protection and makes it last.
Great response. Martin, do you have anything you want to add to that? Anything else that you want to say?
Well, I think that, as I said previously, the flu vaccines we've got were developed in the 1940s. We didn't even understand what antibodies were then. And COVID is teaching us a huge amount, because we're discovering now with COVID the whole issue of breadth of protection, duration of protection. But now we've got tools that enable us to really understand how different vaccines are providing different types of responses to COVID. So it is really possible that out of COVID, we're going to be bringing solutions that can be applied to influenza to help us make better vaccines.
Great. Okay, the next question is, and I think we'll ask Dr. Osterholm to answer this one. How do you overcome the emergence of virulent strains? How can an effective and safe vaccine be introduced in a short time span? Mike, do you want to take that question?
Well, I think that this really goes back to the heart of what Cherry just was talking about, is the need to understand basically the immunology of influenza virus and human infection. And by understanding that, we can apply, in many instances, approaches that are fast forwarded because of that pre-existing knowledge. I think that one of the things we have to look at, that every dollar or every pound or every euro that we invest in research today at the bench level may very well be the basis upon which we understand how we can move vaccines quickly into the public when, for example, a pandemic begins. At the same time, I just want to point out, and something that Charlie said, which I think is very critical, it's not enough to have an effective vaccine, it's about a vaccination. And that ultimately this entire process is going to revolve around not just having vaccines for quote unquote virulent viruses, but also the public acceptance and the willingness and the ability to deliver the vaccines are all going to be part of that same response.
Great. Excellent response. Okay, the next question is, and this is really an important issue. It's how can we attain early detection of severe influenza in a country like India? And that's really important because, we need to be able to track the emergence of new influenza strains. We need to know, how the strains are shifting and changing, and if one is becoming more virulent or becoming a strain with pandemic potential. So that surveillance issue is a really critical one. And I'd like to turn that over to Dr. Kang to answer that question.
So what's happened in the past in low and middle income countries, if we've thought about surveillance, is that surveillance has tended to be very disease specific. You're interested in rotavirus, you build a rotavirus program. You're interested in typhoid, you build a typhoid program, a pneumococcal program, and they're not joined up at all. And with COVID, we've built another separate surveillance program. I think it's time that we started to think about not the bugs, but about the conditions that we are studying, respiratory infections, what looks like a good surveillance program for respiratory infections, because if you want to be prepared for pandemics, you want to be prepared for outbreaks, you have to look at syndromic surveillance and equip laboratories with sustainable surveillance methods, using the same approaches to collecting clinical information and the same laboratory methods, so you can make sense of the data that you're gathering and do it over time. That's not something that is happening in LMICs, and it's something that WHO has called for and really needs to push countries to make sure that they establish these surveillance systems. Otherwise, we'll be doing it again. There's a new vaccine on the horizon, let's think about a new surveillance system. That's unsustainable.
Yeah, very good remarks. The next question, and I think we'll start with Dr. Weller and then others can chime in. What are some of the specific lessons that can be brought from COVID vaccines to accelerate the relatively slow-moving influenza field?
Thank you. It's a great question again. And I think there's a lot in here, because I think one of the things that we had all assumed before COVID was that influenza was going to be the big respiratory pandemic, and we were preparing for that. However, now, we've got COVID and flu and potentially disease X out there. So I think where we are today is changing our thinking about not necessarily focusing on one disease, but on those diseases, as Cherry has just said, that more horizontal approach on diseases which have similarities. And so taking from COVID, where there are disease agnostic approaches like surveillance, where we can really build that capacity globally, and where there are disease specific approaches that are needed, because COVID and influenza are very different viruses with very different natural infection and progression. So understanding what is an area of focus that is horizontal that we can take for many different diseases, and understanding where there's a more vertical disease specific approach.
Great. Mike, do you want to add anything to
No, I think this was
Charlie's
good.
comments?
The one thing I think that I would add to the surveillance piece, which is, as Jerry's laid out very nicely, I think the importance of that is one of the other challenges we'll have as we go forward is the world of diagnostics is changing clearly. And today we're seeing more point of care testing where a viral isolate is not obtained. And in many instances, as we just talked about, the importance of understanding how the viruses are changing over time, we have a real need to know what is that virus looking like, as opposed to just the fact that you have influenza A, H, N something. And so one of the challenges we also will have is to support vaccine research and development. We're going to also need to have that constant a source of viruses from the community so that we can look at what that means in terms of vaccine protection and how that impacts on our work with the immunology of humans and the virus itself.
Great. Martin, do you have anything to add on the whole COVID, key lessons from COVID? You've been very immersed in both issues over the last couple of years.
Well, yes, and I see a question in the chat asking about, well, how is mRNA going to work? And this is a very good question that we've got in the chat, pointing out that it's not really protecting against strains. So one of the things we did learn from influenza is that the immunity, we've got immunity to the hemagglutinins, of course, important for sterile immunization. Immunity to neuraminidase is also important, yet our vaccines don't really touch neuraminidase. We talk about H5N1 or H1N1, but there's no really N1 in there. So now with mRNA, we would be able to actually produce the neuraminidase in a conformationally intact manner. So first of all, the use of RNA is going to enable us to make antigens that previously we've not been able to make. And when we grow up the whole virus and we inactivate the virus with the classical inactivation agents, well, this really destroys a lot of the antigens. So RNA is going to give us ability to make the B cell epitopes in the correct manner. But also the RNA is able to induce cell-mediated immunity. Now, we've seen from other studies, there's studies from Laura Gilbert, that getting a T-cell immunity to influenza, to the core proteins, the nuclear protein, this does provide protection. But we haven't been able to achieve this protection with a classical inactivated vaccine. And the use of the live vaccines doesn't work very well in older children and adults. But mRNA might be able to address all of these answers and more. So I think that what we're learning now from COVID, plus what we've learned from the past of influenza, I'm really optimistic about us being able to now make vaccine candidates that we'll be able to test. The challenge is going to be doing that testing and deciding which one is best and when is the button, when we press go for manufacturing.
Mm-hmm. Martin, this is kind of a follow-on a little bit to what you were just talking about with mRNA technology. But are you aware of other exciting technologies that we can also, we hear so much about mRNA, but are there other technologies that you think are promising and fit into this whole ecosystem and discussion?
Okay, well, there are many technologies. So first of all, of course, we're seeing increasing use of adjuvants. Now, adjuvants have been used in influenza. This has been brought up that we've had the oil and water emulsions widely used during the pandemics, but they also now are used for the vaccinating of the older adults, vaccination even of some pediatric populations. But I think the real emerging technology now is going to be, we've spoken about mRNA, viral vectors. For many years, we thought that viral vectors were things that could only be used once or twice. But the emerging data suggests actually we can boost repeatedly with the viral vectors. So we've got that opportunity. And when we look at how easily these can be manufactured in low and middle income countries, what the cost of production is, this might really be a superior candidate to our current embryonated eggs, which are being used pretty much everywhere. So the other technologies, I think also we've made huge advances in immunology. We are better able to actually dissect the immune response that is being induced upon vaccination and the immune response that's being induced upon infection. And how does one correspond to the other? So it's, for those of us working in vaccines, it's an exciting time.
Great, great. And thank you for that, those clarifications. The next question I think will go to Dr. Osterholm. Why has there been such slow movement in influenza vaccine development when a vaccine is likely to have a very large market?
Well, I think it goes back to the very basic issue that Martin just highlighted, is that we had relied on a technology that gave us at best sometimes successful, sometimes not so successful results. And so there hasn't really been the enthusiasm to embrace this vaccine for seasonal flu, which then in a sense undercut its very possibilities for pandemic flu. I mean, how often do you invest in technologies or in major programs that may one day be needed for a pandemic 5, 10, 20 years down the road? And so I think the lack of that vaccine that could basically be used year round and have really improved results has been a hindering kind of activity. So, but I think that's changing as we now see, as we understand that the potential for seasonal flu is very important. As Cherry indicated a moment ago, you know, in India today, that's not a practical issue. But with better vaccines that could reduce the number of doses you need from one every year to one a decade or whatever, those are the kinds of things I think that will fundamentally also change how we look at vaccines for flu. And also now with the current pandemic, I think people are realizing this is an insurance policy for whenever the next pandemic occurs. We need to have vaccines that either can be immediately available or even have been used prior to the emergence of that pandemic strain, but covered by the protection of the vaccine.
Anybody else want to add anything to what Mike has said? Any other comments on this issue, on slow movement when there's likely to be a very large market? Any comments?
Well, I'll really only add that the market has unfortunately been declining a little bit over the recent years. But where we really need to see uptake are the low and middle income countries. And we won't see uptake there until we've got better vaccines. So I think there might be a bit of disconnect between what people see as the current market and the reliability of the future market.
Yeah, excellent points. Okay, the next question is directed specifically to Dr. Friede. mRNA-based vaccines have the potential to speed up vaccine manufacturing, but how do you envision not having to apply it every year considering antigenic drift of the flu viruses? The question stems from information indicating that alternative, more universal responses are not necessarily more effective than current vaccines. Any comments on that statement?
Okay, well, I tried to answer that in my previous answer, where first of all, influenza is not the same as COVID. There is a difference. Influenza does not present all of the same challenges that COVID presents in terms of viral bypass of immune mechanisms. But the existing vaccines that we've got for influenza do not provide cell-mediated immunity. They do not provide immunity to neuraminidase. So first of all, we may be able to make vaccines that provide cell-mediated immunity to the conserved proteins. We'll be able to provide also immunity to the neuraminidase and also immunity to the conserved regions of hemagglutinin. So it remains to be seen, but the theory says we can do it.
Great. All right. The next question I think we'll take to Dr. Kang. This question is, should the protective immune response against circulating strains documentation be strengthened in regions? Why do we not yet have routine immunization programs so that protection through new vaccines could be tailored for these regions? And would this be highlighted in the new roadmap?
I think one of the reasons that we haven't had vaccination before is what Martin and Mike alluded to earlier. The fact that if you need to keep vaccinating and keep vaccinating, especially when you look at low and middle income country budgets, that's just not going to be possible. But the other part of the question, which is around prior exposure, determining how well vaccines perform, is really something that has not been well studied in low and middle income countries. There are a few studies that have been done in Southeast Asia, some studies in Central America that have looked at these issues. But by and large, influenza and what prior exposure to influenza means in terms of responding to vaccines has not been well elucidated. Add to that the fact that when we look at seasonal patterns of flu, they are very different in different parts of the world. Do you see one peak? Do you see two? Is it something that is maintained year after year? Well, actually, in many cases, we just don't know because we haven't had the surveillance programs that allow us to answer these questions. I think there is a lot of potential for vaccines in low and middle income countries, but there are actually very few low and middle income countries that have looked at introducing these vaccines into their programs. It's complicated because the issue of acceptance, which we discussed a while ago, was highlighted after H1N1. When vaccines were recommended for healthcare workers in LMICs and maternal immunization programs were recommended after H1N1, the uptake of those has been very little. And when we think about new adult immunization programs, I think we're going to have to look at both science and society to be able to get those vaccines to do what they are supposed to be doing.
Excellent points. The next question, I think we'll start with Dr. Weller and maybe others can chime in. Would it make more sense to focus on developing a more universal vaccine against influenza B viruses, since there are only two lineages and humans are the only reservoir? If we are not able to make better vaccines against influenza B, how can we expect to make better vaccines against influenza A?
Now this I'm going to have to pass on to someone else, but I think it really highlights the focus of the roadmap, not only on one approach, but on having multiple approaches to development, because we need to spread our approaches, spread our bets on how we can push this area forward to get those universal flu vaccines. And it's hard. I don't think we should, we need to recognize how difficult scientifically this is going to be. Mm-hmm. But I think either Mike or Martin or Cherry can probably address it more specifically.
Okay, Mike or Martin, do you have a comments on why not push for B?
I'm never scared to weigh in, even if I'm wrong. So, if we were to be making a universal new technology, and then combining this with a standard A, this wouldn't make a lot of sense. So currently, our A and B are produced using the same technology, and we've got a Sept process. So universal B would be good, but this must be combined with a universal A. It does not make sense to have a classical A with a universal B using two different technologies, two different manufacturing approaches, different stabilities, different everything else. So a nice idea, yes, and maybe a universal B might be easier to make than a universal A, but a universal B as a standalone will not be a viable product for public health. Over.
Good points. And then the next question, and maybe Mike can start with this and then somebody else can pick it up. Are we giving up on the idea of improving live attenuated influenza vaccines? I don't know, Mike, if that's a question you can answer. Maybe that's another one for Martin, but if you want to take a stab at it.
Well, no, I think Martin already alluded to the fact, and he's absolutely right, that we have a challenge with live attenuated vaccines in older children and adults. And, what does that mean in terms of protection? And so the technology surely has been successful and important in younger children. But so far, I think we've had some barriers to success in older individuals. That's, to me, the number one challenge. Martin, you obviously have already addressed this issue.
I fully agree with you, Mike. The only thing that I think we could potentially be looking for is to be getting them into even younger children. So currently the lower age cutoff of 2 years means that many children will either have already been infected before they receive LAIV, or they will have received the inactivated vaccine before they receive LAIV. And as Cherry alluded to, this idea of imprinting of the immune system, maybe it would be very good to be using LAIV at a younger age, but I think we've still got some way to go before we can get there.
Great response. The next question I'm going to go ask to Dr. Kang, because it's really right up her alley. What is the role of microbiome studies in advancing the field of influenza vaccines?
Well, I think the gut influences everything. So our immune system only matures appropriately if, that's determined by the gut microbiome. But I think we also have to move beyond the gut microbiome to think about what's happening in the respiratory tract, what's happening in other places, and how that shapes the immune system. We have some data from some vaccine studies that show us that the microbiome matters in terms of the amount of antibodies we make and the protection that we get from vaccines that are targeting mucosal surfaces. Is this something that is going to hold for all vaccines? Well, we have some data from influenza vaccines that are injectable that you can have the microbiome influence that. Most of these studies are done in high-income countries, and whether this is something that will translate to all parts of the world is not clear yet. We know that even if you look at differences in immune responses across Asia and Africa, there are huge differences in what kinds of antibodies are made, and there is preliminary data to show that it relates to the gut microbiome, but I think we need to be doing a lot more research before we figure this out. Are we going to wind up giving a kind of microbiome pill along with the vaccine? I doubt that very much, but I think we will be able to answer questions about the kinds of people in whom we might need to tailor vaccination strategies.
Great response. And I do want to point out, Dr. Osterholm had to leave us at a few minutes before the hour. He has another engagement. So unfortunately, so he's not with us for the rest of this. We have a couple more questions before we close. And the next question is, we are seeing a considerable emphasis on COVID-19 vaccines that protect from severe outcomes. On the other hand, we have seen a desire to have vaccines that protect from mild disease and transmission and assume that these would protect from severe disease as well. How would the roadmap prioritize this aspect of the target product profile? And I think I'm going to ask Martin to take a stab at that. And then if Charlie has anything she wants to add, that would be great.
Okay, I think that's an excellent question, and I'm not sure that I'm going to be able to answer it completely, but certainly for influenza, because there is this huge, first of all, there is an animal, it's zoonotic as well. So we've got to be really concerned about this continual transmission from birds, from pigs and other animals into the human population, which is continually causing major shifts in what we're subject to. For us, and in much of the discussion of the roadmap, the severity of the disease became very important, that especially in low and middle income countries, it is severe disease that is the target. And if we could have a vaccine that protected against severe disease universally, while not really protecting against the sniffles, we felt that would already be a big jump forwards. But as we've seen now in the discussion around COVID, discussions around vaccines that prevent transmission are also very important. So I think I'm not answering your question. I think it's a very good question. And this is one of the topics that is addressed in the roadmap of saying we need to be comparing these various aspects.
Great. I think we'll ask one more question. I think I'll ask Dr. Weller. Do you think that all the work that's gone into COVID and all the focus on COVID will set back influenza vaccine research, given the influenza or given the emphasis on COVID over the last couple of years, or how do you think these two can play out together going forward?
That's a really interesting topic, because I think it's kind of a double-edged sword in some ways. That on one hand, COVID has highlighted, promoted, pushed forward that political willingness and understanding, and partnerships have been formed around a respiratory disease of pandemic potential, which influenza is one of. And now there are many reports, discussions, reviews ongoing globally about how we can prepare for future pandemics, which would include influenza as part of that. And we can learn so much from influenza. We know so much about influenza compared to COVID. So there's a lot of learnings from influenza that we can share. But on the other hand, that focus on COVID is potentially a threat to the influenza area. So it is a double-edged sword, and I think we'll just have to see how it plays out. This roadmap is really highlighting the specific gaps and prioritizing the specific gaps to push forward. I think one of the things which would be really valuable to do is what the roadmap has done, is highlighting where COVID and flu can come together, and there are similar solutions to both diseases.
Yeah, excellent. Martin, do you have anything you want to add on that?
I think Charlie answered it perfectly.
Terry, anything you would like to add from your perspective?
I think particularly when we begin to think about LMICs, what I'm seeing is really worrying me. This is everything else is being ignored for COVID. And that's medical care, surveillance, and research. And that's not a situation that we can allow to continue. If we are to look towards the future, this is not our last pandemic. There will be others, and it's likely that there will be flu.
I think that's a great note oh, go ahead, Jerry. You froze there for a second.
I'm done.
I think that is an excellent note to end on. And I think that I think we've captured most of the questions, and we're just about at the top of the hour. So I want to deeply thank our panelists. I deeply appreciate your time and your expertise and your support, your continued support of this project. And I also will extend that to Mike separately. Again, thank you, everyone. And thanks to all the participants who agreed to join us and are here with us today. And as Mike said, and early on in his remarks, that part of the most important, I think Charlie made this point as well, one of the most important aspects of the success of this roadmap is in partnership and in the community, in taking ownership on the part of the influenza R&D community. So we're looking forward to interacting more with all of you in the future. And again, I want to thank you very much for your time today. Have a good day, everyone. Bye.
Thank you. Thank you.
Thank you.